You went to bank or something, that's why you went. You didn't find any conversation. Actually, I forgot it. I knew you went to bank, but I forgot for what.
Good evening. This is Dr. Arun Agarwal.
Yes. Dr. Arun, you have to wait for this presentation to get over.
Okay.
So this does not allow consultation outside the jurisdiction of India, and it does not allow research and development online. So this can be used as a B2B model, as a B2C model. That means from a patient to an RMP, or an RMP to an RMP, where a doctor wants a consult from a super specialist. It can be used by a caregiver to an RMP. It can be used by a health worker to an RMP. So these are the multi-modalities of the telemedicine. So if you see this flow chart clearly says that whenever you have a request from a patient for a teleconsultation, either a video, audio, or a text, first you must. So whenever you have a request from a patient, either through a video, audio, or a text, you must identify the patient correctly. You must identify the patient, take his consent, then you should quickly assess the patient. If the patient has an emergency, you should not provide a teleconsult. You should guide the patient how to go to a nearest hospital and take care of his emergency. However, if the patient is stable and you are sure of that, you can evaluate the patient through his history, through his investigations, his past records, and then provide consultation to the patient. So again, the management will be depending on whether you want to counsel the patient, give specific treatment, and when it comes to specific treatment also, there's a limitation on what kind of medicines we can prescribe to a patient. So this is a very important slide, and it talks about the highlights of the new telemedicine guidelines. There are 5 important parameters. First, a good consent has to be taken, and the patient understands the shortcomings of an online consultation since it is not a physical examination. Patient should also be identified properly, and his previous records like his discharge summary or his OPD slip should be seen online so that he can identify the patient properly. After talking to the patient, which should be a good audible connection, you should be able to give a good quality digital prescription to the patient with his name and the MCI registration number and the date clearly mentioned on the prescription. A trail of all the consultations and the prescriptions is desirable to maintain either on an iCloud or a dedicated server. And if and when the professional fees is charged from the patient, a receipt should be generated and sent to the patient by an email or a phone, and proper deduction like a TDS has to be done. Now, what are the restrictions on the prescription? Which are medicines which are listed in the Schedule X of Drugs and Cosmetic Act and psychotropic drugs should not be prescribed through telemedicine. However, all doctors are allowed to do teleconsult in all states and union territories of India. So consult to all states and union territories is permissible under the Telemedicine Act. Now, all of you will agree that the most powerful tool today we have is a smartphone. So a smartphone solution is a need of the hour because of its availability and because of its reach. So I'm just going to share with you a smartphone application which all of us are using in Gangaram Hospital. It's a simple application called as My Follow Up. It is freely available both on iOS and Android platforms, and patient can easily download this application. It has 2 aspects. First important thing is when the patient logs in, he has to read this terms and conditions which clearly say that patient understands that this is not the best way, it has its limitation. He is ready to take this risk and he understands everything. Once he takes this terms and condition and his consent is taken, only then we proceed towards the consultation. As you can see in this application, you have 2 aspects. One is the patient aspect and one is the doctor aspect. So when the patient uses, he has to use the red button, which is his aspect, and then the doctor uses it, he uses the blue one, which is his aspect. So when it comes to the patient, first of all, he has to identify his doctor. He has to see this time slot of this doctor. Then he can book a call with the doctor. The doctor gets an SMS that this patient wants an appointment with you today, 7th April at 5 p.m. If I am free, I will say okay. The patient will get yes. Your doctor has approved the call. Then the patient goes online. He pays his doctor, and then he can upload his reports using his camera, or if he has a stored PDF file, it can be uploaded. So now I can bring you to the patient side. Now you can see this is the doctor's side. As a doctor, that when I get a request from the patient, you can see on my screen in the center, I can see the ultrasound report, the investigations report, the CT scan report, and also a small note which the patient can. So I can see the reports. Now I'm very sure which patient I'm talking to. I have all the background, and after seeing this, at a scheduled time, I have an IVR call generated in which my mobile number does not get displayed to the patient, so that there is secrecy, and I'm not bothered with with other calls later on with the patient. And after talking to the patient, you can see on the extreme right, I have a good digital prescription which can be either typed through 4 small buttons, or if I'm sitting in my OPD, I can just write it on my letterhead and click a picture and send it to the patient. So in 3 simple steps, the patient can upload his details, and in 3 simple steps, the doctor can see it, and the moment the doctor sends the prescription, the money is transferred into his account, and this is how the patient gets the consultation, and this is how the doctor can take care. Also, I think you must have seen a lot of videos which is going around the world from Europe, from America, and from China, is the relevance of telerobotic. Telerobotic is a simple mobile control device which you can control with your phone, in which you can have a robo moving around in the ward, in an isolation room where you don't want to get infected through the patient. And I'll show you a small video of a chat which we did in a remote place in Welspun has a big factory in Anjar, and very recently I did a consult. You can see this is, I am from Delhi, and I'm controlling the robo with my phone, and I come close to the patient. Now this is a patient sitting in an isolation room. There is nobody else. This is a suspected case of COVID. So you can see now I can talk to the patient and I can address all his concerns without actually being present there, and this can be really useful in the times of. So this is one aspect. Again, there other aspects like these things are remote control trolleys are available. These also you have seen in your WhatsApp group. These trolleys you can actually send the things which are required to a patient's bed without actually sending your healthcare staff and exposing them to the virus. So this is how it has a tray which can hold stuff, and you can, using a simple joystick, you can manipulate them into the ward and you can send them across. It has an onboard computer control. You can bring it to the patient, you can chat with the patient, you can reassure the patient. And sitting in your clinics, you can monitor maybe 10 patients in your ICU, provide them the medicines that are required, and you can minimize the personal contact with the patient. So these are all situations which we never encountered before in our life. Now that we have encountered, we have seen how this pandemic has shaken and stirred everybody. So healthcare needs to be strengthened, and I think we'll have to think out of the box and think for solutions. So what COVID-19 pandemic has taught us is that we have to rethink strategies. Work from home is becoming a reality. Online consultations are here to stay. Webinars are the need of the hours. Zoom meetings, tele-robotic connectivity, virtual connectivity, having virtual telemedicine centers in smaller states has really become very, very important. And I think India, with its diversity, with 80% in India being in small places, we can use technology to connect with our villages and provide them so smartphone is going to be the most important tool to disseminate and share knowledge. All applications and all these things are going to be smart based. So just concluding, I would say stay at home, stay safe, Stay healthy and stay blessed. Thank you.
Thank you so much, doctor. Let's change. So moving to our next session, which is to Dr. Atul Kochar. I will request Dr. Atul Kochar to take this forward now. Kochar, can you hear us? We have some technical issue here, so let's move to the next session, which is by Dr. Gyani. Sir, can I request you to please take this forward now? I think we are facing some technical thing. Just give us a minute. Let's sort it out.
Hello.
Dr. Atul,
Hello. Yeah, good afternoon.
sir, you are loud and clear. You can start the session, please.
Yeah, good afternoon to all of you. And thank you so much to all of you for giving this opportunity to NABH to represent its stand. I mean, this is a very exciting session and very timely session, which I must say, and I must congratulate ASSOCHAM for organizing this and giving NABH a chance. NABH, as we all know, is the flag bearer of quality for healthcare organizations in India. And since 2005, NABH has established itself by a range of standards which are accredited by ISQA and is carrying on the banner. And this is one area where the telemedicine or the digital health standards or the virtual care standards, which is the need of the hour. So the entire presentation by Dr. Kalhan was very, very precise, very crisp, and he took us through the entire range of the scope of this. And there's so much to come also. And this is a wonderful time, and every person has a smartphone literally, and that is only going to increase. And with that, it's mind boggling about the reach. But at the same time, I must say that there are so many gray zones, so many wrinkles to be sorted out, to be ironed out, and that is the thing which hello
Sir, you're audible. Please
hello
go ahead.
Okay, so that is the thing that we need. The need of the hour to is have establishment which controls, not only controls, which lays out certain basic ground rules for practice. The recent document by the Niti Aayog, NMC, MCI, which came out, is a wonderful document. And what is the need of the hour? But it still has so many gray zones which need to be sorted out very well. And that is where NABH can play a very, very important role. And I must say, we have already done the groundwork, and there's so much to be thought of. Actually, when we talk about telemedicine, first the nomenclature itself, actually, the world moved ahead of telemedicine. They moved on to digital health and virtual care and whatnot. So we must, as a consensus, first decide what is the entire scope of this range which we are talking, and it is immense. Then we have to think about the hardware part. What is the basic hardware compliance which we can look at? Then the ethical part, the moral part, the consent which Dr. Kalan very well spoke about, and that it has to be precise, and all those things have to be really laid out. And then beyond consent, there's the issue of the confidentiality and the integrity of data. What kind of encryption are we looking at? What kind of storage? What kind of, where on what servers do we store, if at all we are uh, storing this data? So the confidentiality of each patient is as important as in a real life clinic, or that kind of data we have to maintain. And that is what NABH aspires to do in the coming few months. We have founded the committee. It was already founded, rather. We have a board approval for that. And these digital health standards, which includes and which is very comprehensive, has lead members, most of the clinicians and technocrats who will be hand holding us. They'll be drafting, then we'll be putting it in the public domain, and then we'll be inviting comments for all of us. So the basic point being that we need to have, because it's a pan-India authority being given to conduct these telemedicine standards. Pan-India authority has been given by the telemedicine first draft, which came out last week, and all the clinicians and healthcare workers are very excited about this. Dr. Kalan already took us the entire range. There's so much to look forward to, but again and again, I'll say that we need to iron out those wrinkles. We need to iron out those gray zones, and we need to have a firm basic thing. Basic groundwork should be in place, which outlines each and every aspect of, from the patient care angle, from the staff care, from the confidentiality and everything to be put in place. And there comes the role of NABH, because we have well-defined standards, well-defined standard with objective elements in practically all domain areas of healthcare now. And these have been going on. We are into the fourth cycle of ISQA, and we hope to emulate and put ourselves and give to the nation a very robust standard, which will sort out things for a long time to come. So that is my basic premise, and I don't have a formal presentation, and unfortunately I can't share the screen with you right now. And we have Dr. Gyani also, who's a stalwart in his own right, and so many industry people, and Dr. Upasana itself is a lead player, and I'm sure we'll cover more in question and answers part. But I again say that NABH is looking forward to drafting and implementing these standards with the support of the industry. So thank you once again for this opportunity. Thank you so much.
Thank you so much, Dr. Kocher. So moving to next session is through Dr. Geeta Gyani. Sir, over to you. Sir? Dr. Gyani, can you hear me? Dr. Gyani, I request you to please start the session. Sir, can you please unmute yourself? I think we should move to our next panelist. I request Commander Navneet Bhai to start this session. We'll connect Dr. Gyani after this.
Yeah, hi, good afternoon, everyone. Am I audible?
Yes, please.
Yeah, thank you very much. And first of all, I think it's a wonderful feeling to be here amongst such an august gathering, and welcome to all of you who are today linked into this webinar. Thank you very much for joining. And I think it's absolutely, right, the kind of session we are having right now. We're not sitting in some plush five-star hotel. We are connected on the video link and talking remotely. And I think that's what this webinar is all about. I'm going to talk to you about two things today. I'm going to talk to you about, I'm going to talk to you about two things today. One is the ecosystem which is developing across us in the healthcare system. And second, a very, very pertinent question which is not being talked about so much today because we are in the midst of this battle, and that is about the confidence levels amongst the healthcare workers, the doctors, the nurses, the paramedical staff. Just to take you back in history, in the last 6 years, the world has seen, four major pandemics, which the WHO has characterized as pandemics. It was 2014 Ebola. Then thereafter, there was another breakout of polio in 2014 again, and 2016 Zika, and then 2018 again Ebola came back, and now we have Corona amongst us. If I were to draw comparisons, and I would just take Ebola right now. March 23rd, 2014, it seems quite prophetic. The month of March is when WHO declared Ebola as a pandemic. It's very important that although Ebola had a mortality rate of around 70% when it started, and I think panned out to around 40%, the R naught for Ebola was around 1.5 to 2.5, which is quite similar to what Corona is. It's around 2.8 today. Just to give you some data here, it was less contagious but more deadly than Corona. Around 60% of healthcare facilities were not ready when Ebola broke out. And 92% of healthcare workers were not trained to tackle Ebola. When interviewed and when spoken to, around 50% of healthcare workers were not willing to go and treat a Ebola patient on their own. Around less than 50% were ready, and around 1/3 of them wanted insurance for themselves and for their kith and kin. Now let's come back to what the situation we have faced. I think it seems quite deja vu that even today, after so many WHO worldwide crisis calls and pandemics that we have been through, it is exactly the same situation as it was many years back. I think more than 70% of our facilities are not ready, or maybe more than that. And I think almost 100% of our healthcare workers were not trained and not ready for this epidemic. And also, you must have heard these things in media. Many doctors, many nurses are very reluctant to actually treat patients. Of course, they are doing it and they are doing a wonderful job. But if you ask them, and the reason for this is very simple, and the reason is that the preparedness. So the ecosystem is quite similar to what it was many years back. The only difference is that social media today is so strong, and social media has put these things right on our face, and we are now faced with all sorts of WhatsApp messages, everyone giving a new treatment, n number of messages going on about this virus. So I was talking to a very senior infection control doctor, and also someone who had gone through these things in last around 10-15 years, and he said that social media has played a major role in creating the kind of hype which is around coronavirus. Not to take away the seriousness of the whole issue, but I think that was very important. Now, to look at the confidence levels of healthcare workers, how do we make healthcare workers confident of treating this what it is right now on us? I mean, I'm talking about coronavirus. And I was reading a nurse's interview who faced Ebola virus, and she very rightly said that please do not consider a pandemic as an emergency. And there is no emergency during a pandemic. When you have a pandemic and you have a patient shouting, crying in an ICU, you better take those 7, 8, 10 minutes to don your PPE and go inside the ICU. Because if you yourself are going to fall sick, then first of all, you're going to be a burden on the healthcare system yourself. And if you, God forbid, something happens to you, you have one person less to go ahead and do this. So look at the confidence which exists today in our healthcare workers, and the why we are faced with the situation that we are in. So there are two very important criteria. One is the personal protective equipment, or the PPEs, and the absolute lack of it across the board. I think for many years now, suddenly we have a huge surge of demand of PPEs across the world. I was just going through a post as far as US is concerned. Industrial tape, cotton, foam, elastic bands. These are not something which are required, which are terms being used for a 5th class nursery project, but these are the equipment being used to make PPEs in a country like USA. They have been told to make bandanas and scarves and their masks. I mean, I'm talking about a much developed country. So, I mean, so the same thing exists across the world today. Lack of PPEs is one big major hurdle today why healthcare workers are not very confident of going into a ICU or treating a COVID patient. That is one single reason. The second important thing is about testing. Obviously, this is a new virus. Every day we find new methods of and techniques of testing. There are rapid tests available. There are tests which take around 24 hours to the result to come out. There are many news going off of negative results, and that makes again the healthcare workers quite underconfident to treat the patient, because they are not very much confident whether a rapid test gives you a presence of virus in a patient who has not developed antibodies or who has developed antibodies. What happens if the patient turns positive after some time, whom you have treated, and then the whole cascading effect of thing whole takes place. The next important point which came up when I was discussing that was the role of senior doctors and heads of departments across the hospitals. Now, since data is now started coming out that this virus is more, has a higher mortality rate in people who are above, let us say, 60 years of age, many of the head of departments, many of the senior clinicians, and rightly so, themselves are quite, circumspect, of how to, go about treating this thing. So the leadership which should be there right now, for reasons which are not, very wrongly projected, is at today quite missing. So how come the junior doctors, the nursing staff, the paramedicals are going to become the frontline staff to treat this virus? So overall, hats off to many of these countries which are actually facing a huge amount of influx in their ICUs, huge amount of mortalities in their countries. I mean, look at the entire Western world, most of the developed countries. I mean, the Prime Minister of UK yesterday was in the ICU, and then hats off to them that despite not having adequate PPEs, not having adequate protection, having very little knowledge about this virus, not having adequate testing, but still they are going into the front line. So hats off to the healthcare workers. India, that way, I think our country, I don't know, scientific data is still, to come out. We are not yet sure what it is. So far, if you look at the world graphs and an Indian graph, although the cases are going up, but you hardly have any patients in the ICU. The deaths have not been so much, rampant, and somehow we have been lucky. Are we ready today? I think, I would say no, not yet. But I think we have been given this window of opportunity, which is clearly upon us now to maybe get ready in case, God forbid, we also go the way Western countries have gone. I mean, the virus can behave either way. We are not sure about this so-called genetics and things like that, which are now coming out in the forefront. Confidence levels will move up across our healthcare systems if the doctors and the nursing staff and the paramedics have the adequate PPEs. The next important would be the testing, and when both these things are in balance, I'm sure the confidence levels amongst the healthcare workers, which do have an extremely difficult task. And one more thing was, many of the doctors, they've said that when they go back to their families and this virus can go on your as fomites on your dress, etc. And so that is another big cause of worry. I will just close here by saying that I think we have so far done an excellent job as far as containment is concerned, lockdown, etc., maintaining isolation, etc. But I think this time is on us to get our act together as far as the PPEs are concerned, as far as the testing regimes are concerned, so then more and more confidence level builds up amongst the healthcare workers. Thank you very much.
Thank you, Dr. Commander Namit Bali. Moving to next, I will request now Dr. Chaturvedi to take forward. Sir, over to you. Sir, I request you to unmute yourself.
Unmuted. Okay, fine. Am I audible now?
Yes, sir.
Yeah, fine. Thank you very much. Thank you, Sudhir. Thank you, SHM, for organizing this very, very topical and very relevant topic. So we are already seeing a huge surge in telemedicine practice. I think in US there's some 7-fold increase post-COVID, and I believe 2020 will be a watershed year, as Sudhir showed. The regulation has come out in March of 2020, which was lying in the back box for a long time, inbox for a long time. So this is typically what is happening. And for me, telemedicine, being an oncologist, is a very big game changer in our practice. Almost 70% of the patients I see in my OPD do not need to be physically there. If we really use their telemedicine properly, we will save so much of resources and time, and deploy them properly, that it is going to be a game changer. And we are already seeing a lot of effect in our practice. In fact, at Max also, we are seeing a huge surge in telemedicine practice already. So for me, telemedicine has 3 components. Teleconsult has 3 components. One is the consultation per se, what you generally have with a doctor. The other part is the digitalization of the medical records. So once that digitalization happens, it has huge impact for the patient, for the hospital and the doctor, and also for scientific world at large, because a lot of this digitalization will lead to better documentation and understanding of disease per se. And the third component is what we can add on this is the AI and machine learning. Typically, when you sort of digitalize things, then a lot of AI and machine learning tools can be applied, and that can actually give a lot of insight into disease and management, and again, deployment of resources. So I'll briefly take you through the spectrum of cancer care and how this is practiced, and where I see it will be a game changer. So in the spectrum of cancer care, from prevention to palliation, the whole spectrum has 6 components. So I'll just touch upon 3 things so that to give an example how it is impacting. So the first and foremost thing is prevention, screening. Can we impact that by telemedicine? Diagnosis, can we impact? The answer is a big yes, because a lot of our business are already there, and a lot of people come to us in the OPD, very small things which are not significant, and sometimes ignore those small things that are going to be very significant, and delay that because they can't travel to the hospital and take time out. But if you have in a different time zone, if somebody can take a picture in the evening and put the record and subject that to for a consultation, not able to take time off from office to visit the hospital and visit a doctor, but they can put that data and put that for doctor's input, and certainly in an oral ulcer or a lot of things we can diagnose that this is or this is not, and schedule a time better for a more forward looking treatment. So that is like triaging the treatment early. Second component is what happens typically once the diagnosis is done, that staging happens and treatment plan is made. So this treatment planning is typically in oncology practice a multimodal approach. What we have is tumor boards. So once you have digitalized, today what is happening, most of the centers are having physical tumor boards, where all the doctors sitting together and engaging and discussing case by case. In a virtual tumor board, which is possible in a telemedicine world or a teleconsult world, you have a digitalized data which is shared by all the specialists in the team on a virtual way, and all the essential inputs are taken. So in the physical time, in a physical way, you are sharing only in 5 minutes, you're covering 3 or 4 cases, which otherwise would have taken 40 minutes, 50 minutes, and your accuracy goes up because digital data is more accurate, more precise, and you're not missing important points. So that is also an important area where you save time, you get more accurate, and you add AI to this. So what happens, the AI will suggest that what are the treatment options, what is the intent of treatment, and that gets more and more defined and better output. The third aspect is that most of our patients are lost to follow up and do not have appropriate, I would say, we lose data on their survival and their problems subsequently. But if in a digital world or in a telemedicine world, even this accuracy is going to increase significantly because the people can give their inputs from remote areas. Today, we have patients coming for follow-up from far away areas, which is not so important so many times. But out of fear, apprehension, teleconsult will make that easy, make that possible and accessible. Today, we lose a lot of our data because of the people are not approachable and they are not able to reach us. So once that also improves, this will change the documentation and the understanding of disease much better. So I will say that in the oncology world, just in the rest of the healthcare space, in the oncology world, this is going to be a big game changer for all the three players, the patient, doctors, and hospitals, and the evolution of knowledge and science. And we really look forward to a very keen evolution of application of telemedicine in a big way. And remember, 2020 will be the changing days. Thank you very much.
Thank you so much, doctor. Right. Thank you for such informative information to all the participants and us. So moving to next speaker, I will request Dr. Manjari to take this forward, please.
Am I audible?
Yes, please.
Can you? Good afternoon, everybody. Thank you for being a part of this beautiful session. Thank you, Asijam, for organizing it. At Max, we're already doing online consults. In fact, Max has, like every other hospital, come up with that little telemedicine app that patients can download, doctors can download. But you know, because I also work largely with wellness, which is not really preventive but more treatment related wellness, we know that there is a huge opportunity for people who do not need to physically come in to see their coaches or doctors or healthcare you know, practitioners in a space where we're already looking at, you know, I mean, besides the fact that the COVID-19 has taught us that social distancing is going to be the new norm, another thing that we are seeing around us is the impact of less travel, the impact of less emissions to the environment and to mankind in general. And I think if that pace can be continued with people continuing to travel, you know, reach out to people more in an online platform, that will be eventually the future that is not just okay for medicine, but also generally the future for virtual world to exist for mankind. And we see that happening already in many businesses. I think medicine was one business which never really took on to tele platforms, because although there is Practo, Healthify Me, and so many other platforms available, but we never took them completely because there was a physical touch that was required. Now with social distancing being the norm, and because it's going to be quite difficult for patients to keep coming back as physical patients to the hospital, I think this is the future of medicine in many specialties. Of course, as Dr. Kalhan very clearly told, that there are a lot of limitations to telemedicine, including surgeries, including patients that need to be physically examined, and including anthropometry and vitals and stuff that needs to be done. Thankfully, now with gadgets coming in and with our phones being converted into smaller gadgets that can monitor our heart rates, our BP, our blood sugar, our vitals, our BMIs, our percentage body fat. So a lot of information that we want as vitals can also be taken via a small gadget or a smartphone, and therefore that need to come into the doctor to get all that done will also be wiped out. So eventually going forward, a lot of information, we know that lab services are already at home services. We know that pharmaceuticals are already at home services. So the only thing that needs to be brought together is now the doctor seeing the patient wherever it is not an emergency or a trauma or a surgery related condition. And in these conditions, because the paucity of people traveling less will be there, it is, I think, the ideal way to do. In terms of future of telemedicine, because I remember long back, around 10, 15 years back, I was working with Apollo very long back, And Apollo had started telemedicine. Manipal had started telemedicine, in fact, in Bangalore, and they were doing it in smaller pockets around Bangalore, wherein all the referrals would come in. And these people, of course, were physically traveling to Manipal, to Bangalore, and it would really ease out if the telemedicine was more robust. I think the problem with telemedicine is that the systems are still not robust, and that is why the trust factor that should exist between the physician and the patient is still not established. But as the systems become more robust, as Dr. Harit says, as AI becomes more integrated, as algorithms are built up to put everything in order, and so that, like you have a computerized tomography, you can also have an AI system putting everything together and generating a beautiful prescription for the patient. So whatever is advised to the patient need not go like a document. It can go as a treatment plan to the patient. Follow-ups, of course, reviews, reconsults, any form of clarity can always be done on the phone. Another important advantage of doing telemedicine is that it also is the physical burden of staffing in a hospital, which means that from the reception to having lines on people who will be doing billing to having systems to do all these things, which are essentially patient care coordination activities, a lot of that burden gets reduced. So that way, that load is shared. And when the load goes down, that can be added on as a revenue exchange that can be given to the patients. So consults can become cheaper for patients. They can become more affordable because a lot of things are cut out from the center or from the middle of the interaction. There are a lot of challenges with telemedicine. All of us already know that. But I think the biggest challenge with telemedicine is that we're not able to physically meet the patient. And we know that healing especially has there's a sense of reassurance that you get when you meet somebody or you shake hands or give a little hug. So that is something that, of course, will always remain a challenge. I think beyond the physical intimacy and the touch and the reassurance that comes with a physical meeting, everything else almost can be done by systems which are led by technology. And because Niti Aayog has already come out with guidelines in the government and the MCI has already given its go ahead, I think it is, of course, the future. And a lot of people who are not, toying with the idea of telemedicine should quickly get on board, because patients are not going to travel to doctors. And it's going to be extremely important for all of us to adapt to this technology. Thank you so much. And of course, there's no formal presentation. I wasn't asked to make one, but maybe going forward, we can have these webinars much more organized, where more information like Dr. Kalhan can be put into presentations that can then be shared with the members, because that becomes more organized and more substantial information. Thank you very much.
Thank you, Doctor. Yes, certainly we will continue to be more on online, conducting webinars of all relevant topic like one of this. So thank you so much for your time. Now I request all the participants who are attending this webinar to please post your question in the question section. We will take up this question with the panelist to answer this. So request you to please post your question. I am giving this to my colleague Anshul to take forward this Q&A session. Anshul.
Yeah, hi, good afternoon, everyone. Thank you all the distinguished panelists who have joined today for your very insightful and informative address. So I have one question and I wanted to Dr. Sudhir Kallan to address this. So how do physicians will examine the patient in teleconsultation, like measuring the heart rate, blood pressure, temperature, etc.?
See, I'm telling you that telemedicine has actually exploded, I would say, because of our need in this pandemic. And telemedicine is also evolving, and we are all in a learning phase. So I think, as I've said in my own presentation, first thing we should concentrate on is getting used to telemedicine. That means identify your patient properly. Start, first of all, taking care of your follow-up patients. Patients you already know of, you have the records with you, you know the background. Don't indulge into emergencies. Slowly, gradually, as we can, as Dr. Manjari Singh and Dr. Harith was saying, as we can incorporate various devices onto it, for example, a pulse oximeter can be added, an ECG tracing can be added, an otoscope can be added, and artificial intelligence can be incorporated into that. So till that time, we are all in a learning phase. Till that time, we cannot get into that and we don't get used to that. We should be a little careful about telemedicine.
Thank you so much, sir. So my next question is to Dr. Harith. So what's the best modality for practicing telemedicine in India, sir? As per you, sir.
Unmute. Harith, you have to unmute yourself.
Sir, you are not audible. Can you unmute yourself, please?
Unmuted. Fine. Now I'm audible.
Yeah.
So I think what Sudhir was mentioning and what Pyle also mentioned, that physical contact and emotional contact, these two things are missing. But remember, robotic surgery is a reality today. A lot of things are not required, and today we see as this will incorporate, it will grow. To me, telemedicine has come out of age, so we don't have to wait for anything. Just keep doing it. We keep evolving with time very fast. Now, for me, in oncology, this is a game changer for all specialties. I think for whether it's diabetes or bariatric, I'm sure what Sudhir does every day, all of us what we are practicing, it's a game changer because see, almost, as I said, 70% of my patients do not need to be there in the clinic to consult. Only 30% can come for consultation. Remaining 70% can come offline, and we can handle a lot of that data, and we can do what is called forward triaging, so that they come and see the relevant doctors with the appropriate record and spend less time in the hospital. So similar things will apply in every zone and every practice. Today, in post-operative, in immediate follow-up, 3 months, 6 months. So a lot of things are happening which can be limited. I do agree, physical examination is not going to happen so easily. It's not going to happen so soon. But I do not see that it is not. It is being a big, what I should say, it should not be a big limiting factor. It will certainly get sorted significantly to be able to use their time appropriately.
So do you think that teleconsultation through WhatsApp and through this Facebook Messenger would hamper any of like in the security region and everything?
So each one of us in practice is today using WhatsApp already. I am using WhatsApp for my post-op patients even today when lockdown has happened. One of my patients in Noida, I asked them, they had some issues about the wound. They showed the pictures through a WhatsApp video and we advised. So I am saying every tool, end of the day, there are 6 things to measure. Is the access possible? Is the data accurate? Is it convenient? And if we have a software and people are not going to access it, then it's difficult. But something which is simplistic and possible to do, it will definitely be a hit. How so many things have gone off the table for all of us in our day-to-day life, we can just realize anything which is convenient, simple, cost-effective will come off like age, and this is going to happen. I think WhatsApp will also play a role. Everything will join together.
Thank you so much, sir. So my next question is to Dr. Manjari. Ma'am, though we know that telemedicine is now legal in India, but can you please tell to our audience what are the use cases or conditions which can be treated with telemedicine? Ma'am, can you please unmute yourself?
Can you hear me, Anshu? Can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah, thank you for the question. Essentially, as Dr. Kalhan had also already spoken in his presentation in detail, anybody who requires an emergency treatment, anybody with trauma, anybody who requires a surgical intervention, anybody who requires something that needs to be physically examined. For example, if it's a wound, if it's a cut, if it's a fracture, if it's any such thing really which needs to be physically examined by the doctor, are things that are out of privy of telemedicine as of now. I'm sure going forward they will also come in the preview of telemedicine. But simpler cases where an internal medicine patient needs to see an internal medicine doctor for simple things like high cholesterol or blood pressure or diabetes or PCOD or conditions which are also called metabolic disease or metabolic syndrome, including hormonal imbalances, autoimmune conditions, neurological conditions, children with all forms of neurological conditions. All of these can be successfully done on the telemedicine platform, because most of these conditions are conditions that need the doctor to understand what is going on with the patient. The doctor needs to see the reports of the person, the latest, if there are any radiology investigations, if there are any blood tests. These need to be shared over the app or over the telemedicine platform, basis which prescription can be made for the patient, and going forward, successive follow-ups can be done. So most of these conditions can be done, except as we discussed, not attempting surgery. Dr. Harit spoke about robotic surgery, but then robotic surgery is, of course, very closely monitored in a hospital setting. It cannot be done in a remote location as of now. So most things that come under the cardiometabolic syndrome or neurological conditions or autoimmune conditions or hormonal imbalance, these are conditions that can easily be treated, or initially we can start these treatments on the telemedicine platform. As Dr. Sudhir said, for people to get used to telemedicine, it's better to take older patients and start the process with them instead of attempting it with somebody you don't know as of now.
So, ma'am, you're also saying that services provided by physiotherapists, dentists, psychiatrists, etc. They can't be covered in telemedicine as of now.
Dentist, no, because a dentist has to do a procedure. Yes, you has to literally work inside the mouth of the patient. A psychiatrist, yes, all forms of sessions, psychiatric counseling, psychiatric cognitive behavioral therapy sessions, all forms of such sessions can be done. And the third thing you said is a dentist, a psychiatrist, and the third thing you said is
Physiotherapist.
Again, a physiotherapy is more like using a machine to do a certain relief, or relieving a certain part of the body, it could be a muscle or a bone or a joint or a tendon. So in that case, sometimes you may require physically to be there. If you can teach it to the patient, then the patient can probably.
So, Dr. Kallan, want to add something? So, can you? Yeah, please.
You see, today, I would like to say that telemedicine has actually is born out of necessity today. It is exploded because of it being the need of the hour. And we are all rediscovering telemedicine. There's a question that I have one of the participants saying that, do we need to store the data of the patient? See, today the government very clearly saying use WhatsApp, use Facebook, use whatever you want, but please be in touch with your patients. This is an extraordinary situation. Okay, today. But tomorrow, when we get out of this situation and telemedicine, we'll all realize it is still a reality. Then we'll have to organize, I would say, what we do on our WhatsApp or an email in a very good format. That is what I'm saying. A good consent has to be taken from the patient. A trail of all the conversations that you're doing with the patient need to be maintained either on a dedicated server or an iCloud, so that you can get back to them. Some, you even might have to required to record all the conversations that you do with the patient on a server, because tomorrow there might be some legal problems. Also, it is very important that you give a good quality prescription to a patient, which is legible, which has the patient's name, which has the name of the doctor with his MCI registration. So there is no, and he can actually show this digital prescription to a chemist and get the medicines from him. So telemedicine will have to evolve and slowly, gradually. At present, I think we all agree that I would like to bring down the number of visits that a patient has with me. For me, a patient-doctor relationship cannot be a blind date. I cannot, without examining the patient and start giving medicines right, left, and center. It is not be possible till we really have all the tools that we are necessary. At present, what I would like to do is bring down the number of visits that a patient has. I'll give you a simple examination. A patient comes to me. He wants a surgery. I invite and tell the patient to get some investigations or an ultrasound done. The patient goes away back. He doesn't have to come back to show me the reports. I can see that online. Harit has got his patient who's on regular follow-up, and he tells him to get some biochemical investigations done. He doesn't have to come back to him. Harit already knows everything about that patient. And Manjari wants to advise the patient about nutritional, so she already knows everything about the patient. So that is the kind of evolution of telemedicine we are looking for.
Thank you so much, sir. So you talked about this prescription in your talk. So is there any
Yes.
current format that the prescription needs to be issued by the doctor to the patient during
See, very
teleconsultation?
clear. There are 5-6 parameters which are to be very clear in any prescription. I think whether you give it physically to a patient or a digital prescription, first of all, the name of the patient, his age, the sex, the date you have examined the patient, okay, and the name of the doctor with his MCI registration number is very important. The name of the medicine, the frequency of the medicine, the duration of the medicine, any special remarks about that medicine, whether it has to be taken empty stomach or after meals, and what are the the precautions to be taken. So all these things which are regular prescription you would give in your OPD is what you need to give for a digital prescription also. So the parameters remain the same, and your answerability and your responsibilities remain the same. If only it may
Okay, sir.
more.
So you mean to say that the patient can account you liable in the court of law?
So today he is not going to, because this is an extraordinary. That's what I'm saying. Today is an extraordinary situation. He might not. And today you see
Okay.
people clapping and acknowledging doctors and saying, and tomorrow these people will, when it's not there, they'll turn around and start suing you also. So you must understand that things change. So if you are going to do digital or a telemedicine consultation, then you'll have to be medico-legally sound also. That is what I'm saying, that you have to also safeguard yourself. That is why I said you must first of all have the terms and conditions, 12-14 terms and conditions, and there should be a tick box which the patient should sign, and that consent should be available to the provider, that yes, the patient accepted the limitations of a teleconsult. Secondly, you going ahead, you might have to keep a track of all the consultations that you have done. Some of the good sites also keep a backup of the conversation that you've had on their backend or on their servers for some time, like a month or so before they delete, so that so these are the things we'll have to do. You can't run away from a responsibility. If a patient comes to your clinic and you advise and you don't give a legible prescription or a wrong medical, you are liable for the liabilities, isn't it? So medical legal
Right, sir,
application will be there on this also.
Right, sir. Right. Thank you so much, sir. So my next question is for Commander Bani. What do you think? What will be the major challenges and barriers in introducing telemedicine to a rural to remote health?
Anshu, we had a small OPD center in Kashmir. I started it around 2 years back in Srinagar, and we had a small hospital there called Classic Hospital. We went and established a small telemedicine center. It ran for quite some time before, of course, the issues cropped up and things like that. But I think, technology has surpassed geographies and boundaries now. So, I don't think there are any major issues, except, of course, if there are issues of bandwidth, there are issues of internet connectivity. I think they are more technical in nature, and also more of barriers of intent and the way you want to do it. Otherwise, I remember the deputy commissioner of Leh Ladakh. They wanted us to set up a small telemedicine center in Kargil. And they said that we'll provide all infrastructure, everything. And I think, in all its fairness, these are the places which actually require telemedicine, corona or no corona. I mean, when corona, tomorrow, 3 months down the line, touch wood, or maybe, some months down the line, when corona is behind us, I think if telemedicine can circumvent this and it can go into remote locations, remote places where there are no doctors at all, places where, where people actually require, we did a camp in remote Baramulla and a small village there, and, they said that during snowfall, people just die. I mean, there is nobody to even look at them. So, I think telemedicine has to circumvent all these issues, except for, issues of technical, which, and, like I told you about, I think those are issues also which can be easily, taken care of. I think the time for telemedicine and to move into remote areas, I think it should happen in the future.
Thank you so much, sir. My next question is to Dr. Atul Kochar. So, do you expect telemedicine to cause a paradigm shift in healthcare? If yes, will it significantly alter patient-physician relationship?
I would like to answer it in two parts. One, as a practicing dermatologist. Uh, as a practicing dermatologist, we've been handling, consultations or other prescriptions on WhatsApp or email since these technologies came into force. So that is one angle to it. And we've seen a very, very low pixel photograph moving on to real immersive technology where you don't really, you can see minutest skin pore also sitting across the screen. So that kind of technology is also available. So what Dr. Commander Bali said, that the remote area, these things are all very fine. Dr. Kalan also said that the reach of this telemedicine is mind-boggling, actually. And there are certain specialities which are already practicing. Dr. Manjari also said that all these things, that the imaging part, the nutrition part, the physiotherapy part, the you raised, I mean, doing an exercise in front of a screen, that is a good example of a telemedicine. But the physician patient relationship, what you specifically asked, is a art, actually, and there that touch is important. So till we moved into the eighth sense, where the eighth digital sense, where touch technology is there, which already people are working on, but those things, specifically talking in the Indian context, as a clinician, as a physician, I would say are still far. That we are still debating the evidence-based medicine versus experience-based medicine. We, as in India, we cater to some really low socioeconomic challenges. We cater to very different strata of this thing. But yes, in a small percentage, as far as the reach is concerned, there's going to be a paradigm shift. For example, Commander Bali said the Kargil thing, those inhospitable areas are approachable suddenly. And we ourselves have offered consultation on a screen, and going forward, like Dr. Harit also said, that there's a forward triaging, which is a wonderful concept. So before the patient, you know what exactly you are dealing with. So you are, in a way, healthcare organizations are already prepared for these challenges. So then that element of mystery is not there. And a visual connect itself takes care of, if not 90, maybe about 50 to 60% of the issues. So that is very, very important. But again, I would like to second, third Dr. Kallan, Dr. Sudhir, what he said, that once the dust settles, once the madness subsides of this corona thing, then the real issues will come forward. So you have to have an infrastructure in place. And as a NABH, I mean, we aspire to offer a very, very solid standard which takes care of the patient's interest also, the hospitals and the staff and the doctor's interest also, so that everybody is protected and everybody's interest is taken care of. So that is what at NABH we are working for, and we hope to deliver by December basic good season draft, which is cemented by some backed by some leaders in the field, and we hope to solicit your opinion and suggestions for that. So thank you so much. There's going to be a shift. How much of a paradigm is that going to be? That is to be seen. So yes.
Thank you so much, sir. We look forward to the guidelines of NABH on this particular things, and so that the hospitals can make sure that telemedicine can be provided in a better way to all the patient tickets. So, ma'am, I wanted to rope in Mrs. Upasana Arora. Ma'am, I have a question for you. What is your view on telemedicine? Is it a useful way to reduce healthcare cost?
Please unmute yourself.
Ma'am, still we can't hear you.
Is it okay?
Yes, ma'am. Now you are.
In this scenario right now, we all are suffering from this big problem, corona. Telemedicine is the only answer. When nobody wants to go to the hospital, and even doctor is not interested to see the patients all the time, because we are supposed to maintain this social distancing. So right now it is very good. And now it's legal, so there is less complication in telemedicine. But same time, I don't know, as Dr. Kalhan said, after this, when this problem will be over, then what will be the future of telemedicine? But same time, I think for follow-ups, telemedicine is a very good thing because it saves lots of money and time and energy, everything. Somebody who already met a doctor and doctor knows his case, then he can take telemedicine advice, and it is going to be really beneficial for everyone. It will be a win-win situation for doctor as well as the patient.
All right, ma'am. Thank you so much. So this is the last question from my side. So as you know, like India is facing the shortage of healthcare providers. And when the telemedicine has come up, do you think that because if in the case where the new patient comes up to a new doctor and he doesn't, the doctor is not aware of his past medical history, so how the telemedicine will take care of that particular issue, sir, to actually take care of the medical history of the patient who is new to the care deliver, sir, to the doctor? Yes, sir. Please.
You see, that my question is to Dr. Kochhar also. See, we are talking about virtual clinics, and I think the only way the national healthcare programs can be implemented, because we are so short of human resources, to have a kind of a first, I would say, a D2D model. Let's think of a small district where there is a primary healthcare worker, maybe a small MBBS or a BIMS doctor. He is qualified enough to take the history of a patient, take his temperature, take his blood pressure, pulse. But beyond that, he does not have the expertise to further guide the patient. So if we can use technology to connect those people, today I tell a specialist, I can't expect Dr. Harit Chaturvedi to go to a small center and advise about oncology. But if that patient can build up a small initial health capsule of the patient and discuss with Dr. Harit Chaturvedi, he wouldn't mind doing it at sitting in his comfort of his office having a cup of coffee. So if you tell Dr. Chaturvedi that every week you have to take out 1 hour for providing distal teleconsultation to a small district, he would be more than happy, and so would I, and so would many of us. But because we don't waste time on traveling, so that is what the future is. We have to build up first with D2D, then, in this budget, I'll tell you the two big things that the government did was, one, I think 2 lakh villages are going to be provided with an optical fiber. So if Harit would remember, about 22 years back, Harit and me sat down over a cup of tea and we wanted to, start teleconsultation. That time a server was not available. It was 2M, the speed was so bad that we had to, drop the idea. And ever since, we have always been struggling about telemedicine. I think the time has come after 22 years, and that too, I think, thanks to Corona and our own crisis. So in India, typically takes a crisis for a clarity to develop and things to develop. So I think, and again in this budget, what has been done, and Dr. Kochhar will vouch for that, is a smart move which the government did was that they provided a smartphone to all the healthcare workers. So a multi-purpose health worker has been given a smartphone. A multi-purpose healthcare now is connected to all of us. A small village, a chopal, has been provided with an optical fiber. You just have to put a laptop there and talk to them and advise them about prevention, about hand hygiene, about menstrual hygiene, about immunization, about screening for cancer, about so many things, good nutrition, what is a good diet, how to prevent iron deficiency anemia. I think the scope is endless. And this is the only way, I'm repeating myself, this is the only way in which we can address the diversity of our country. This is the only way we can reach out to the rural India, which really needs it. At present, our healthcare system was developed like a pyramid. And the strong thing was the base, the primary health center. What has happened in the last 20 years is that it has become an upside down pyramid. The tertiary care centers, we have the big Apollo, the Max and the Gangarams in metro cities. But what has the primary healthcare done? The primary healthcare has shrunk. And what we have is an inverted pyramid. That's a failed healthcare system. So we need to correct that.
Right, sir. Very rightly said, sir. Sir, what my last question to Dr. Kochhar, sir. For practicing telemedicine, it's actually essential that we have a unified electronic health records. And is NEBS is working anything on this particular aspect?
See, government has already notified the draft guidelines, which are the Disha guidelines in respect of creation, maintenance, and encryption and security of the electronic health records. And there are other guidelines. The OSHA guidelines are also there, and so many things are there. But as a country, we need to move forward solidly, and there are multiple agencies working on that, and everybody has to be on board. And I second and third that this is a major way to reach out to people. Dr. Sudhir, Dr. Cullen said, and this is the major way. This is the major way where you can reach, and this is just like flying a drone. You know, in US, they have fought the entire wars in Afghanistan and Iraq, sitting in Washington DC. So this is just something of that, but still we are a long way to go. I mean, there are sectors where we can increase the reach, but how much time? So that human angle has to be preserved, that the basic essence of a medical consult has to be preserved, and automation is welcome, the reach is welcome, and the reach is mind-boggling, no doubt about it. But how to give the entire thing a structure? You have to lay down the basic framework, and by no means is it going to be a final structure. This is just going to be a version 1, and then we'll have 1.1, 1.2 to 1.n and 1.z, and so that is always there, but a good beginning has been made. And I would again like to thank the august panelists and the SHM for bringing this burning topic right now. I'm thankful, and hopefully this panel, this debate itself will be a kind of a foundation for further things to come. So I'm in total agreement with all of these esteemed panelists that the telemedicine is the need of the hour, and the reach is mind-boggling. It's going to be a paradigm shift, and we are here just to create a basic framework and a structure which can be built upon, to the moon, actually. So thank you so much. That's what I have to say.
And Dr. Kochar will also need a draft policy on data protection from you.
Of course. So we are in compliance. All those guidelines will have to be incorporated. Our standards are not prescriptive; they are generic standards, and they'll be whole encompassing, and they'll meet the basic national framework on all policies. So this is my submission, and this will be a good standard which will be produced in the coming months. So thank you so much.
Thank you.
Thank you so much, everyone. So here we end up our question and answer round. And I will request Mrs. Upasana Arora ma'am to kindly give her closing remarks and word of thanks, please.
Thank you, everyone. First of all, I'm really thankful to SOCHAM that they have organized a very, very useful and wonderful webinar. So I'm thankful to Meenakshi, Payal, Anshul, and Rohit. And now I should say thanks to my dear panelists, Dr. Harit, Dr. Kalhan, Dr. Bali, Dr. Kochar, Dr. Manjri, Dr. Gyani. And this session was really good because we are going to use this knowledge, whatever we gained to talk when we were talking to each other. And I think within a few days, we are going to organize another webinar. So it is very useful for patients like Dr. Harit is dealing with the patient who are actually their immunity is very weak. So telemedicine is very useful for them. They need not to come every time to the hospital to gain more infection. So, you know, telemedicine is a very useful thing, and I am thankful to all of you. Dr. Bali, you have given a real example that you have set up a telemedicine in Kashmir, which is before some time it was really hard to go there. So I am proud of you, and thank you, everyone. We will meet soon again. Thanks a lot.
Thank you, madam.
And one thing,
thank you so much.
history, this era is going to written in golden words for healthcare workers, because हिंदी में जिसे कहते हैं स्वर्ण अक्षरों में हमारा नाम लिखा जाएगा, because इस समय health workers are working very hard, selflessly. Thanks a lot.
I totally agree with you, ma'am. And first of all, from all the SOCHAM team members, participant, we on the behalf of them, we thank you for being lifesavers for us. Thank you so much for your time. Thank you so much, everyone, for attending it. Thank you so much.
Thank you.
Thank you.
Thank you, everyone.